Imagine this. Suddenly, it feels like a dark curtain is being pulled down over your vision. It might cover everything, or maybe just part of it, and it's totally painless. It only lasts a few minutes, maybe, but it's incredibly alarming. That really vivid description comes straight from the source material for today's deep dive.
It's a very striking image, isn't it?
It really is. So today we're taking a deep dive into Amaurosis Fugax. It sounds maybe a bit complicated, medically speaking, but the revision notes you've provided give us a fantastic map.
Yeah, absolutely. And our mission today is really to unpack these notes, pull out the highest yield information, the really key stuff,
Right.
and help you understand this condition thoroughly, but efficiently. We're basically guiding you through the essentials from these notes.
And this really matters because, as the source highlights pretty clearly, this temporary visual loss is often a critical warning sign, something you absolutely shouldn't ignore.
Exactly. A major red flag. So let's start right at the beginning with the definition. The notes define Amaurosis Fugax as a temporary painless loss or reduction of vision in one or sometimes both eyes.
And the source puts a real emphasis on that description you mentioned, that really distinct curtain-like or shade-like effect. It feels like a key way to remember what patients actually report.
It is. It's very memorable. And the underlying cause is a temporary disruption of blood flow, specifically to the retina or perhaps the optic nerve.
Ah, okay.
And this interruption of supply is precisely why it's such an important warning sign. It strongly suggests an underlying issue with blood vessels, maybe further upstream, and it needs prompt medical evaluation.
So it's not usually a problem in the eye itself causing the vision loss. It's more about the blood getting to the eye.
Exactly right. Think of it like a supply line issue. The notes state these episodes typically last somewhere between, say, 5 and 15 minutes.
Okay.
And crucially, Amaurosis Fugax often presents as a type of transient ischemic attack, or TIA.
Right, a TIA, like a mini stroke, people sometimes call it.
That's the term, yes, a mini stroke. And these episodes, this Amaurosis Fugax, can sometimes even come before a more serious, full-blown stroke or even permanent visual loss. It's a warning.
Okay, let's unpack this further then.
Yeah.
What actually causes this temporary disruption? Where does the problem in that supply line originate?
Well, the notes are very clear on this. Often, the cause is a transient ischemic attack. A TIA means temporary poor blood flow, usually thought of in relation to the brain. But in this context, it's affecting the blood supply to the eye's retina or optic nerve.
And what's the most common reason for that TIA affecting the eye? What's behind it?
The source points overwhelmingly towards atherosclerosis.
Ah, okay.
That's the buildup of fatty plaques inside the arteries. These plaques can narrow the arteries, obviously, or bits of them can break off, forming blood clots, or what we call emboli.
Little fragments traveling in the blood?
Precisely. These fragments travel through the bloodstream, and if they happen to lodge in and block the small blood vessels supplying the eye, well, that's when you get the temporary vision loss.
So it's like debris clogging a pipe, basically.
That's a good analogy, yes. Like debris in the body's plumbing system.
And that plaque breaking off from, say, the carotid artery in the neck, is that a common scenario described in the notes?
Absolutely. That's mentioned as a frequent source of these emboli. But the notes also list other potential causes.
Such as?
Well, emboli can come from the heart itself, perhaps due to certain heart conditions. There can be vasospasm, where the blood vessel temporarily clamps down really tightly.
Right.
Increased blood viscosity, thicker blood that doesn't flow as easily, or just generally reduced overall blood flow for various other reasons.
And are there specific medical conditions the notes flag up as potential triggers?
Yes, they specifically mention conditions like giant cell arteritis, or GCA. That's an inflammatory condition affecting blood vessels.
Okay.
And also ocular migraine. But again, the notes really highlight that vascular blockage, usually from atherosclerosis causing emboli, is the most frequent mechanism they detail.
So given all these potential causes linked to blood flow and vessels, who is more likely to experience this? What are the key risk factors listed in the source?
The list includes many familiar cardiovascular risk factors, things you might expect.
Yeah.
So straight from the source, older age is one, a history of cardiovascular disease, things like hypertension, coronary artery disease, smoking, definitely, diabetes, hyperlipidemia, which is high cholesterol, and obesity.
Makes sense. Family history of stroke, or TIA, is also listed, which fits the pattern.
It does, and also certain genetic or acquired conditions that might make blood more prone to clotting or cause other vascular abnormalities.
What's interesting here, and it ties back to what you were saying earlier, is how many of these connect directly to just broader cardiovascular health.
Exactly.
It really underscores that this isn't just some isolated eye thing, is it? It's often a symptom reflecting systemic problems, usually with the blood vessels.
Precisely. It's a sign from the system. Which leads us nicely into how it actually happens physiologically, the pathophysiology. How does that blood flow disruption translate into that temporary vision loss?
Yeah, what's the mechanism?
Well, at its core, as we've said, the blood flow to the retina or the optic nerve gets compromised temporarily.
And the typical reason for that compromise, like we discussed with the causes?
Most often, according to the notes, it's these blood clots or bits of plaque obstructing those vital small vessels that supply the eye.
And this blockage or reduced flow then leads to what the notes call an ischemic episode.
Correct. Ischemia just means a period where there's reduced blood flow and therefore reduced oxygen supply to the tissue, in this case the retina or the optic nerve tissue.
And the immediate result of that temporary lack of oxygen is
Temporary loss of vision.
simple as that.
Pretty much. And it's temporary because usually the obstruction itself is transient. The clot might break up and move on, or maybe a spasm resolves. Blood flow gets spontaneously restored.
And vision comes back relatively quickly.
Exactly. Vision returns to normal. The notes do mention that the duration can vary quite a bit, sometimes just a few seconds, other times several minutes.
Okay, so moving on to what you actually see or feel, the clinical features. The main one we've kept coming back to is that sudden temporary vision loss, usually just in one eye, though the notes say it can affect both.
Right. And to really lock it in your memory, that distinct curtain-like or shade-like effect is the classic description you'll often hear or read about. It's a very helpful detail.
Definitely. And the vision loss itself, can it vary in intensity?
Yes, it can be complete, like a total blackout in that eye, or it might be partial, maybe just affecting the top half or the bottom half of the visual field.
And just to reiterate, these episodes last seconds to minutes before fully resolving on their own. That spontaneity is key.
It is. Associated symptoms, according to the notes, can sometimes include things like flashes of light, maybe some blurry vision during the episode, or even a feeling of pressure behind the affected eye.
But the crucial detail, and this helps differentiate it perhaps, is that vision usually returns completely to normal after the episode passes. No lasting deficit from the event itself.
That's the typical pattern, yes.
Okay, so if someone experiences sudden temporary vision loss, how do doctors know for sure it's Amaurosis Fugax and not one of the many other things that can cause sudden visual disturbances? This must be where the differential diagnosis comes in.
Precisely. It's a critical step.
Yeah.
The source notes list several conditions that can look similar and absolutely need to be ruled out.
What sort of things are on that list?
Things like ocular migraine or retinal migraine, which are related but distinct. Retinal detachment, that's an emergency. Vitreous hemorrhage, which is bleeding inside the eye.
Okay.
Angle closure glaucoma, another urgent condition. Optic neuritis, which is inflammation of the optic nerve. And something called ocular ischemic syndrome, which is more chronic poor blood flow.
Wow, that's quite a list. So how do doctors sort through that? How do they differentiate?
Well, a really comprehensive evaluation is essential. The notes describe this involves taking a thorough medical history, paying close attention to those cardiovascular risk factors we talked about earlier,
Makes sense.
then a detailed ophthalmic examination to actually look at the eye structure itself, visual field testing to map out any vision loss, and various imaging techniques.
Right, like the Doppler scans or MRI.
Exactly. Things like carotid Doppler ultrasound, maybe an MRI or CT angiography. And the aim of all this investigation,
What are they trying to achieve?
it's really twofold. First, assess the patient's overall vascular status hunt for blockages, sources of emboli, that sort of thing.
Find the upstream problem.
Find the upstream problem, yes. And second, definitively exclude those other potential causes on the differential list. The eye exam, for instance, helps rule out things happening inside the eye itself, like a detachment or a hemorrhage.
Got it. And just briefly on the epidemiology, who gets this and how often? The notes mention UK figures.
Yes, they do mention that specific prevalence just for Amaurosis fugax itself isn't perfectly defined in the source notes we have.
Okay.
But they give an estimate for TIAs in general, which, as we know, Amaurosis fugax often falls under. And they estimate around 46,000 annual cases of TIAs in England alone.
So it's not uncommon.
Not at all. And while it can occur at various ages, it mirrors the risk factors, becomes significantly more common in people over the age of 60.
Right. So digging into those investigations a bit more then, how exactly do doctors figure out the underlying cause? The investigation section in the notes lays out the steps quite clearly.
It does. It usually starts with, as we mentioned, a detailed medical history and a physical examination. They're actively looking for signs of underlying vascular disease or those risk factors we listed.
Then come blood tests. What are they specifically checking for in the bloods in this context?
They'll check things like cholesterol levels, blood clotting factors to see if the blood is too prone to clotting, and maybe markers that could indicate systemic inflammation or other vascular issues. It helps build that overall picture of cardiovascular health.
And imaging studies. You mentioned carotid ultrasound, MRI, CT angiography. What's the main focus there?
Imaging is absolutely crucial because they're trying to pinpoint the source of that temporary blockage, if possible. A carotid ultrasound is very common. It looks directly for plaque buildup in those big arteries in the neck, a really frequent source of emboli going to the eye.
Okay.
MRI and CT angiography give even more detailed pictures of blood vessels, helping to identify abnormalities or blockages elsewhere, maybe higher up or in the brain circulation.
What about checking the heart? Is that usually part of the workup?
Often, yes. A cardiac evaluation, maybe with an ECG or an echocardiogram, an ultrasound of the heart is needed because the heart itself can be a source of emboli. They're looking for things like irregular heartbeats, valve problems, things that could generate clots.
And, of course, the eye itself gets a proper look, too.
Oh, definitely. A detailed ophthalmic examination is standard. That includes checking visual acuity, how well you see the chart visual fields, and doing a fundoscopy, which means looking right inside the eye at the retina and the optic nerve head.
And that helps confirm it looks like Amaurosis Fugax and rule out primary eye problems.
Exactly. And depending on what all these initial tests find, the notes mention additional tests might be needed as well.
Right. Tailored to the individual.
Precisely. And this whole investigation process, it really connects back to that central idea. Amaurosis fugax is usually a sign of a deeper systemic issue. The tests are looking upstream at the blood vessels, the heart, the whole system, not just focusing narrowly on the eye. It's about finding the root cause of the disruption.
So once they've hopefully figured out the likely cause, what's the plan? What's the management? What do doctors actually do for someone who's had an episode of Amaurosis Fugax?
Well, the goals are very clear from the source material. Number 1, prevent future vascular events, especially stroke. And number 2, preserve vision as much as possible.
And the focus isn't just on treating the eye symptoms themselves, then?
No, not primarily. The focus is squarely on treating the underlying cause, whatever that may be, and aggressively managing those cardiovascular risk factors we identified earlier. That's absolutely key to preventing future, potentially much more serious events.
So what does that treatment actually involve? What kind of approaches do the notes describe?
It's really multi-pronged based on the source. First off, crucial lifestyle modifications. Things like smoking cessation, stopping smoking is huge, adopting a healthy diet, getting regular exercise. The foundations...
Medications, I assume they play a big role.
Yes, medications are key, both for controlling the risk factors and preventing clots. The notes list controlling blood pressure, cholesterol levels, and diabetes effectively. Then there's often anticoagulation therapy to reduce the overall risk of clot formation, and long-term antiplatelet therapy medications like aspirin or clopidogrel is very commonly prescribed, particularly if an embolic cause, like from atherosclerosis, is suspected or found.
And what if the cause is inflammatory, like that giant cell arteritis you mentioned?
Ah, good point. The notes specify that for inflammatory causes like GCA, high-dose steroids are really the cornerstone of treatment, and often these are needed long-term.
Is surgery ever an option?
Sometimes, yes. In cases where there's severe narrowing or stenosis of the carotid artery in the neck, that common source of emboli we talked about, then surgical intervention might be necessary.
Like clearing out the plaque?
Exactly. A procedure called carotid endarterectomy to physically remove the blockage. The notes also wisely mention the importance of considering the status of the other carotid artery as well, as atherosclerosis is often bilateral.
And follow-up is essential, I imagine. This isn't a one-off treatment.
Absolutely critical. Regular monitoring is needed. Treatment might need adjusting over time. And often it involves collaboration between different specialists, maybe vascular medicine, neurology, ophthalmology, to ensure all aspects of the underlying issue are being addressed properly.
The notes give a few specific treatment details too, don't they, for different causes?
They do. For presumed carotid artery emboli, for instance, the initial treatment often involves a short course of high-dose aspirin, maybe for 2 weeks, followed by that long-term antiplatelet therapy.
Okay.
And if there are other reasons for clots, perhaps coming from the heart, then long-term anticoagulation medications like warfarin or newer agents might also be appropriate.
And going back to those steroids for GCA, any other considerations there?
Yes, the source reminds us that when a patient is on high-dose steroids, especially long-term, co-prescribing certain other medications is important for protection. Things like proton pump inhibitors or PPIs to protect the stomach lining from ulcers, which can be a side effect of steroids, and also bisphosphonates, which help protect bone density because long-term steroids can unfortunately weaken bones.
Right, managing the side effects of the treatment itself.
Yeah.
And reinforcing those lifestyle factors, healthy diet, exercise, quitting smoking, reducing alcohol that sounds foundational, regardless of the specific medical treatment pathway.
They really are. They address the underlying systemic vascular health that is so often the root issue here. The notes also include the specific point about driving.
Oh, yes.
It mentions you should avoid driving for 1 month after experiencing symptoms, and you can only return to driving if the visual symptoms have fully and permanently resolved. That's an important practical point.
Definitely. And if, unfortunately, despite everything, someone is left with some permanent visual deficits, is there support mentioned?
Yes, the notes mention the availability of support through occupational therapy interventions to help adapt to any vision loss, and also considering registration as visually impaired, which can provide access to various resources and support services.
Okay. So looking at the long-term picture then, the prognosis.
Yeah.
What happens after an episode of Amaurosis Fugax? What do the notes say about the outlook?
Well, it heavily depends on the underlying cause that's identified and, crucially, how effectively the individual's cardiovascular risk factors are managed going forward.
But a key point the notes emphasize is that prompt evaluation and getting the right management significantly reduce the risk of having subsequent vascular events, right?
Yes, absolutely. Getting it checked out and treated makes a big difference. But on the flip side, the warning is that there is a potential increased risk of future TIAs or even full strokes if those underlying issues aren't investigated and treated aggressively.
So regular follow-up, sticking with those lifestyle changes, taking the prescribed medications, all of that is absolutely crucial for the long-term outlook and trying to prevent something worse down the line.
Couldn't agree more. And finally, let's just touch on the potential complications. What are the bad outcomes if Amaurosis Fugax isn't properly addressed?
The major complication, as we've really been highlighting throughout this, is that increased risk of subsequent TIAs or, most seriously, a full-blown stroke. That's the big danger.
It is. And if the underlying vascular disease isn't treated and is allowed to progress, it can unfortunately lead to severe visual impairment or even permanent blindness in some cases.
So the message from the notes is pretty stark. Immediate medical attention is crucial when you experience these symptoms. It's all about preventing these serious complications.
Exactly. And getting appropriate, timely treatment is absolutely essential to reduce that risk of future vascular events and protect both brain health and vision long term.
So there you have it. Amaurosis fugax, that temporary visual warning sign, often described so vividly as a curtain falling, is frequently linked to some pretty serious underlying systemic vascular issues, like atherosclerosis.
Yeah, and probably the single most important thing to take away from these notes, the key message, is that this symptom is a significant red flag. It absolutely needs prompt medical investigation to prevent something potentially far more serious, like a stroke or permanent visual loss. It's your body sending a clear warning signal.
It really makes you think, what does this tell us about seemingly isolated symptoms? How can paying close attention to these transient events like a temporary loss of vision be such a crucial early step in potentially preventing major health crises down the line?
It really highlights how incredibly interconnected the body's systems are, doesn't it? Especially that vital vascular network. Trouble in one small part can indicate a much wider problem.
Absolutely. Well, these notes provided an excellent basis for this deep dive, offering a really high-yield look at such a crucial topic.
They were very well structured.
For those of you listening who might be preparing for exams or maybe just want more high-yield medical knowledge drawn directly from relevant sources like these, do check out passthemsra.com.
And for free resources as well to help you keep learning and exploring these kinds of topics, freemsra.com is also available for you.
Keep exploring, stay curious. We'll see you on the next deep dive.